You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 20, 2023. This week, the diuretic duels, adverse events during hospital admissions, accuracy of blood pressure measurements, and left main revascularization strategies again. First up is Transform HF study was published. Now, this podcast, cardiology journals, meetings, and cardiology news sites often feature the big four classes of drugs for heart failure. You know them, the RAS inhibitors, MRA, beta blockers, SGLT2 inhibitors. And our EP devices get lots of attention too, but gosh, the core of helping folks with heart failure and congestion are loop diuretics. And the question of which of these two, the furosemide or torsemide, is best has been long debated. Basic furosemide seems fine for newly diagnosed diuretic-naive patients, but once patients get sick enough to be hospitalized, I've often wondered if one of my secret tricks, torsemide, is actually the better option. And to know that, regular listeners of this podcast know that you need far more than the opinion of an electrophysiologist podcast host. You need a randomized controlled trial. And JAMA has published a Transform HF trial. This was a special trial, a pragmatic trial of furosemide versus torsemide in patients with heart failure. Now, any kind of heart failure. The primary endpoint was all-cause mortality, and there were 5 secondary outcomes. I've previously discussed this trial on the November 11th TWIC podcast after it was presented at the AHA meeting, and since it's such a big, important trial, I think it's worth just a quick relook now. About 1,400 patients in each arm. Now, the standout feature of Transform HF was its pragmatic nature. Patients were recruited from 60 centers after a hospitalization for heart failure. The dose and frequency of the randomized therapy during the hospitalization and after discharge was determined by the treating clinician, but the trial did offer some suggested guides for dosing. And changes in dose and frequency of the randomized therapy after discharge were also at the discretion of the patient's usual outpatient clinicians. And after discharge from the hospital, no further study-specific follow-ups were scheduled. Patients were followed by phone follow-up. Now, the choice of endpoint of this trial is very, very curious, right? All-cause death. Now, I say that because I wonder why the authors thought one brand of loop diuretic would have an effect size so large that it could move mortality signals. I mean, there hasn't been a mortality reduction in a primary endpoint in a heart failure therapy since Rao's trial in 1999 of spironolactone. Well, the rate of death in the two arms were nearly identical, and there were a lot of deaths, 26% in each arm. So now you might wonder, well, what about heart failure hospitalizations? Well, my friends, you don't get to know that. Why? Because the authors did it right. They measured the right endpoint. They measured total hospitalizations. Remember, heart failure hospitalizations are usually one small component of total hospitalizations. And if you're a 75-year-old person, you don't care what kind of hospital admission is prevented. You just want to be admitted less. Transform heart failure authors measured total hospitalizations, and they found no statistically significant difference in the two diuretic arms. I won't even tell you about the subgroups because without even a trace of signal in the main results, it would be foolhardy to look at any one subgroup. Now, before we conclude that the old standby furosemide is where we should start, there were some serious limitations in this trial, and they're important. Now, most of this occurred because it was a pragmatic trial. Pragmatic trials, by definition, have limitations. First was that they reached the target number of primary outcomes, well, that is the death outcomes, but the sample size ended up being half of that was planned. This limits the interpretation of outcomes like hospital admissions. And I've already discussed the second limitation, which is the choice of endpoint. I mean, all-cause death is a great endpoint because there's no bias in adjudication. See also the last 2 weeks' discussions on this podcast of the Fourier trial and the debate about adjudicating what kind of cause of death. But it's pretty far-fetched to think that a loop diuretic choice is disease-modifying enough to move something like a death signal. Another limitation of this trial was the diuretic discontinuation and crossovers. Again, this isn't one of those trials with strict protocols. Pragmatic trials are designed to simulate what happens in real-world practice. And that's good because then the results will generalize well to real-world practice. But it's bad because there's a lot of noise that might hide an important signal. That said, I think this data tells us there isn't a big, obvious, large effect size, and there's no reason to favor torsemide over furosemide in general. But that, I don't think, is the main message. The main message, I think, is the tension between how to produce evidence. The authors show us a roadmap for doing a pragmatic trial that collects outcomes from regular practice, and that is a very good, positive thing. But the noise, the broad entry criteria of all types of heart failure, the dropouts, the crossovers, the varying dosing, the ability to look at only big endpoints, these are some things we're going to have to think about. I spend a lot of time each week critiquing the generalizability of highly selective and highly controlled RCTs. Is my patient in my clinic similar to those in the trials? This is always the question. Well, does the evidence from a trial with oodles of nurse coordinators apply to my patient who can't even find a ride to clinic? Well, at least in a standard, tightly controlled RCT, you get an average effect for that group of patients in that environment. Okay, final 2 comments and I'll move on. Please do read the editorial from Mastermind, Dr. Michelle Kittleson. Now, I say mastermind because of all the debates I've lost, which has been a bunch, Dr. Kittleson most thoroughly shredded me. Now, Dr. Kittleson also has an excellent Twitter feed, and if you're a young learner, you should be following her feed. And she also has a brand new book, which I've looked at the table of contents, and it looks amazing, and it's called Mastering the Art of Patient Care. Now, the final comment is one that she makes in her editorial, and that is the absolutely crucial notion that we have to publish all trials, even those with non-significant results. Now, that's important because of publication bias. Because if the only trials that get published are those with positive results, think what's going to happen when you do the meta-analyses. Okay, second topic is a really big one. Adverse events during hospital admissions. New England Journal of Medicine has published a retrospective observational study from Harvard researchers who studied adverse events during hospital admissions in 2018. Now, the authors frame their study by citing old 1991 data on adverse events, and they say lots has changed for the good. I mean, we've reduced central line infections. That's been a shining star in the quality management space. And we now have electronic data. And we need more of a contemporary look at adverse events during hospital admissions. Now, this whole history makes me feel old because I've practiced through this entire time course, and things I'd say are better. But every month, when the committee I sit on that reviews cases, I think, gosh, we could do better. And then when I look back at my work, I think I could do better. It's so darn humbling, this work. Now, before I tell you a single thing about this random sample of 11 Massachusetts hospitals that the authors reviewed, I wanted to set out 2 important facts about the modern age of medical therapy. And one is that you now have to be very, very, very ill to be admitted on an inpatient service. The second thing to say is related, and that is the best way to avoid having an adverse event during a hospital admission is not to be sick enough to be admitted. And that's the thing. The better we are at keeping people alive longer, the sicker the patients we're going to see in the hospital. For instance, a 25-year-old man who has an SVT ablation doesn't get urinary retention, but an 80-year-old man does. Okay, here's the top-line data from the New England paper. In a random sample of about 2,800 admissions, they found at least one adverse event in 24%. 1 in 4. Now, of those, nearly 1 in 4 were judged to be preventable, and nearly a third of these had a severity level of serious or higher. All total, nearly 7% of admissions had at least one preventable adverse event. And adverse drug events were the most common type of adverse event, accounting for nearly 40%. The second most common adverse event was a surgical or procedural event, and then followed by patient care events such as falls or pressure ulcers. Healthcare infections were about 10% of all events. Now here's a copy and paste from the conclusions. Quote, "These findings underscore the importance of patient safety and the need for continuing improvement." I also found this sentence in the discussion, quote, "Our approach may have resulted in conservative estimates of adverse event rates." Now my comments. While I applaud any effort to improve patient care, I really dislike this paper. I don't know any of the authors, and I mean them no malice, but this sort of work does the work of caring for extremely sick patients a real disservice. First of all, let's start with the methodology. We have nurses reviewing an electronic record for things they identified as an adverse event in hindsight. Nowhere in that review is a picture of the patient or the context of the care or the family sitting by the bedside. This, in my opinion, is a fatal flaw, and here is why. When we review cases each month at my hospital, here's what happens. A physician who has 30 years of experience of inpatient care, who's worked in our hospital, he screens the cases to bring to the committee. Most, quote, quality referrals don't even pass muster for review. And then, of those that are reviewed by a committee of physician peers, a scant minority rise to the level of further inquiry. Now, that doesn't mean we can't do better, but it means when we are judged by practicing clinicians, major issues are rare. Clinician judges with experience realize the sharpness of hindsight and the foolishness of thinking you'd do better without the knowledge of hindsight. Okay, another fatal flaw from this paper comes from a look at the data in the actual tables that list the complications. The most common adverse effect from a drug reaction is hypotension. Again, no context. How in the world would one ever, quote, maximize the rapid initiation of guideline-directed medical therapy in patients with heart failure without encountering low blood pressure? I mean, the only way to avoid low blood pressure with a drug is to stop prescribing any drugs. Now, in the supplement, one low blood pressure episode was labeled as a fatal event after a procedure or surgery. But again, we don't know if this was a life-saving attempt at surgery. There's no context. Retrospective chart reviews lack context. I mean, here's another example from the appendix of a serious and potential adverse event. Patient triggered for low blood pressure and newly developed acute kidney injury with a creatinine of 2.0, and the physician's notes states that both are likely due to overdiuresis. This is nuts. If you haven't overdiuresed a patient, you can't be treating any heart failure patients. Then there are the falls. Okay, falls. You hate for a fall to occur in a patient in the hospital. But how do we prevent such things? Now, one way is to hook up a bed alarm that shriek with VF-inducing decibels. Now, these audible shocks can go off when a patient shifts in bed, and healing in this situation is nearly impossible. Now, I'm not nihilistic. There are ways to improve hospital care, no doubt. One obvious way is to hire enough staff. Another is retaining the staff you have. Of course, that's hard in the healthcare environment we have, and hospitals would rightly come back and say that they can't do any good if they're bankrupt. So this situation is no one person's fault. It's a policy failure. I like to say we get what we tolerate, and voters in America seem to tolerate lousy policy. Now, another way to improve outcomes is to reduce the burden and distractions on caregivers. I mean, those who are taking care of patients, they want to do well, but right now, they have to serve two masters. One is the patient, but the other is the middle manager, making sure that all the boxes are checked. And again, that is a policy failure. We get what we tolerate. Now, every day, every clinician I have ever spent any amount of time with works really hard at delivering the best care possible. It is the peg that we hang our self-esteem on. Motivation is not the problem. Insufficient algorithms are not the problem. Documentation is never the problem. The problem is A, the system, and B, the notion that healthcare can be free of errors. We must, and I mean must, have a discussion of what our tolerance of errors are going to be. And if the answer is 0, there will be tremendous harm. Now, a note on the sponsors of this study. These were the Controlled Risk Insurance Company and the Risk Management Foundation of the Harvard Medical Institutions. And finally, just in case, by accident I'm sure, if a New England Journal of Medicine editor happens by this podcast. I mean, look, we love your journal and we understand the business model of attention and clicks. It's okay. So we have no problem. We'll spot you a few head scratchers, like, say, the Am I Care during the Boston Marathon papers. To err is human, after all. But please, please, when you are sent these flawed observational studies that can bring harm to those who actually do the work at the bedside of the infirmed, resist the urge. Always, please. Stand strong for the people who attend the sick and the vulnerable at all hours of day and night. Okay, third topic is blood pressure accuracy. The World Hypertension League has published a consensus document that is worth a mention, a brief mention. First of all, I did not even know there was such a thing as a League of World Hypertension Experts. Nonetheless, their document calls for urgent strengthening of regulations regarding the accuracy of automated blood pressure devices. And it turns out that most blood pressure measuring devices that are marketed for sale have not undergone adequate validation testing to ensure clinical accuracy. Now, of course, I agree, everyone agrees with such a common sense policy. And the reason to talk about this topic is scale. Few problems could be more relevant to cardiovascular disease than hypertension. But at the core of tackling this problem is accurate and precise, reproducible measurement of blood pressures. A short story. I know of an office, and I won't say which one, that is going to start a blood pressure control quality program. Much like the previous story, there'll be middle managers who are going to begin looking back at the electronic health record to see how well clinicians, doctors, nurse practitioners are doing with blood pressure control of their patients. But there may be a problem with blood pressure measurement. That's because in this office, like so many, I am told, patients have to first struggle to find a parking space. Then they run a gauntlet of paperwork. Then they face questions such as, have you been exposed to monkeypox or been to Uganda in the last week? And then finally, these patients have their blood pressure taken by an associate who's also asking them questions to fill out boxes, again, for middle management. The obvious worry here is that much of hypertension management is about the measurement of blood pressure accurately. The person who records this one blood pressure, manually by the way, will place that number in the chart. That number is often much higher than the blood pressure that patients bring in from their logs at home when they're taking their measurements with an automated cuff, sitting down at their kitchen table. Okay, here's another story. I once spoke with a hypertension specialist at a major referral center, and here is how they take blood pressure. Consider the difference. Their patient enters a room, both feet on the floor, arm at heart level, on a table. Then an automated cuff is in the room. The patient sits quietly and the attendant leaves the room. Then 5 blood pressures are taken automatically every minute. The first one is thrown out, the next 4 are averaged. I mean, that's a lot different. The digital era that we have has created a population of caregivers and patients that are obsessed with numbers and surrogates like blood pressure. And I have no doubt that systolic blood pressure is an important surrogate. But the World Hypertension League is right to emphasize the absolute crisis in obtaining accurate and reproducible blood pressure measurements. For when we record falsely high blood pressures, caregivers intent on looking good to middle managers are going to prescribe more tablets, and that could put elder patients at risk for falls. So my message, therefore, is simple. Before thinking about hypertension treatment, we should always think first about blood pressure measurement accuracy. And finally, if there are any blood pressure experts who listen, please let me know your thoughts. I might be wrong. Obviously, hypertension is not my primary area of expertise. Final topic today is left main coronary artery disease, PCI versus CABG. Again, JAK interventions has published a big real-world examination of revascularization strategies for left main coronary disease in Ontario. The authors used clinical and administrative databases, which are quite good in Ontario, and this allowed researchers to look at all patients having left main procedures without any participation bias. But of course, this was not a randomized comparison. Over the past decade or so, they looked at 1,300 patients who had left main PCI versus 21,000 who had CABG, so way more patients got CABG. The primary outcome was late mortality and major adverse cardiac events. Now, the two groups, PCI and CABG, differed quite a bit in baseline characteristics, so the authors used propensity matching to find about 1,000 patients in each arm that looked similar on a spreadsheet. They confirmed that there was no differences in in-hospital death, but over the 7 years of this paper, death came to 46% in the CABG arm versus 65% in the PCI arm. The hazard ratio was 1.63, or 63% higher death rate for PCI that met statistical significance. And MI favored CABG by a factor of 2.2x. Stroke favored PCI. The hazard ratio there was 0.61. And of course, revascularization was 3 times higher in the PCI arm. The authors concluded, quote, after matching, there was no difference in early mortality, but improved late survival and freedom from major adverse cardiac and cerebral vascular events with CABG. Now, I highlight this paper briefly because it's another great example of confounding, that is, sicker patients getting PCI. And how do I know that? There's an important trick in this paper. Go look at the Kaplan-Meier curves in the main figure, figure 2. The death curves begin separating early, within even a year. Now, no matter how you feel about mortality signals in left main revascularization, do you favor the Excel analysis that showed higher mortality at 5 years in the PCI arm, or do you favor Noble, which showed no difference, or the big Timmy group meta-analysis, which also showed no mortality difference? You know that if CABG had an advantage, it would take years to have an effect. Early separation of Kaplan-Meier curves basically proves confounding in this case. Now, the authors did an extensive amount of statistical adjustments. They always do. Most of these adjustments are way over my head, but always remember, my friends, you can only adjust for that which makes a data sheet. But the doctor or doctors making the decision at the bedside in the real world are using far more than what can be put in a data sheet. And that is the beauty of randomization. It balances all the measured and unmeasured confounders. So I agree with my friend Milos Milojevic, who wrote the excellent editorial. He said what is needed to answer this question is another very large left main coronary artery disease trial. Or maybe this could be done in a registry-based system, say like all those beautiful sweetheart studies. A final note. My thinking is coming around on this topic. 2 more points I'd make. If you take the average patient, CABG looks like it's clearly the best option. But I also have no doubt that the iterations in PCI allow for care of the non-average patient who may benefit from not having to go to surgery. The second point is, come on, y'all, look at revived BCIS, ischemic cardiomyopathy, revascularizable lesions, PCI versus medical therapy, and no difference. Medical therapy now is amazing. So the Salem Youssef meta-analysis that showed that CABG was better than medical therapy, that's from another era. I think we really need another left main revascularization versus medical therapy trial. And when that trial shows that medical therapy performs as well as revascularization in left main disease, then, maybe then, we'll all begin to believe courage in ischemia data. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a brief review. These little things go a long way to help others find us. And of course, also, if you disagree with me, let me know. Disagreement is allowed and encouraged on the TWIC podcast. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.